We're about to talk about the one aspect of bladder cancer that nobody ever talks about, but at the same time, long term, you say, all right, well, you've saved my life, but you took away some of the best parts. So let's talk about sexuality and bladder cancer post-treatment and all these other aspects. I'm really delighted. Come on up, please. To introduce Dr. Svetlana Avulova. She did your fellowship at the Mayo Clinic and started doing her BCAN Young Investigator research while there, and then has moved to the Albany Medical Center in Albany, New York. So we brought New York to you because we also have two wonderful patient advocates here to share and be part of the dialogue. So Dr. Avulova is going to talk about sexuality issues, and then Brian and Elisa are going to give you some input, and we will save time at the end for Q&A. So take it away, Dr. Avulova.
Thank you, Stephanie, and thank you to BCAN. So first of all, let's everybody get up and just kind of like shake it out, because sometimes it gets really stiff sitting for long periods of time. Don't you think so? Yeah, we're like really. And then please, everybody come sit closer. There are two tables right over here. If everyone can fill them in here, come as close as possible.
Bring a chair.
And bring a chair. You don't necessarily have to come and sit at the table. Come, everybody, please.
We won't bite.
We'll wait. We're still gonna.
There you go.
Yes. Closer.
More intimate, she means.
More intimate. Thank you.
You're welcome.
Sometimes I can be a little demanding.
Good.
All right, so we're gonna start off with a question. Well, we'll sit down. This is, as Stephanie said, Dr. Elisa de la Roche, and this is Brian Billings, and I'm Dr. Avulova. So first, I'd like to start off with a question. Who can define sexuality? How do you feel about yourself in a sexual way? Okay, I like that. It's good. It changes. Okay. Anyone else? Yes. Gives you energy. Willingness to connect. Okay. Anyone else? Identity for anyone? Living in the moment. Vulnerability. Choices. Hope. Hope. Elisa, Brian.
I think for me, it has a lot to do with self-identity. And I think somebody had mentioned that. And I think sexuality versus sex, two very different things. And sexuality is much more personal, internal, I think a way we reflect ourselves to others.
Mm-hmm.
Yeah. I combine it with sensuality and pleasure. So, and things that give you pleasure can be sexual or not sexual, but sometimes they can overlap.
Okay, we have a question right there.
That's, yeah. I think it's identifying with yourself, the changes that you have developed over the years, that you don't look the same as you did as a child, and you have certain thoughts, feelings that are different from the way you felt when you were a child. And you look around you and you sometimes even compare yourself with other people because you may have a little bit more than some other people have, and you realize that you're at a stage now where you're having certain urges, certain feelings, and certain thoughts that you didn't have before.
Okay. And this is before, I mean, we didn't even bring up bladder cancer yet. This is just sexuality, right? So a lot of people talk about cancer as they use a lot of war analogies, and some people don't like that. Some people like that. So what I would say really briefly is that sexuality ends up being a casualty of the war against bladder cancer. And like any casualty, we really need to take care of it in a holistic way. So that's why we're here today. We're going to come up with ideas and strategies of how to create in our perfect world the best center for dealing with this casualty of this war. And I will, full disclosure, I'm a urologic oncologist. I am the one that causes pain. I am the one that hurts you. And you guys are here to help me help the future you. You have to, right? Because we just talked about sexuality. It's hope, it's choices, it's feeling good. It's identity. And unfortunately, sexuality changes after bladder cancer. It changes. So that's sort of the whole point of today's talk is it's a free forum about how do we create the best hospital, right? The best treatment algorithm, the best environment to treat sexuality as a casualty of this war. So, Brian, if I may ask you, when would you have wanted us to tell you that sexuality was going to be a casualty?
In my cancer experience happened very, very quickly. And so there wasn't a whole lot of time to get used to the idea of cancer, much less impotency, right? So I had a radical cystectomy and a prostatectomy, and I have a neobladder. So there's so much to think about. And when I would ask my doctors, what about sexuality? What are my performance abilities going to be? How is sex going to be for me after? The answer that I was given was, we have people to talk to you about that. We will get to it at a later date. And I kept thinking, no, now is a good day. Like, how about right now? And I think their concern was not wanting to overwhelm me. But what they didn't understand is that it became something that I worried about so much, almost more. I mean, I had no comprehension of what it was to have your bladder taken out and have it replaced with a neo. It's such a mysterious concept. It seems, almost unbelievable. But the idea of becoming impotent, I could understand instantly. No explanation given about what the healing process would be, how long that would take. And I really wish that I had had those conversations as part of the initial conversation. You have bladder cancer. We now believe you are going to have a surgery which will radically alter you sexually. And these are the ways that we believe we can help you. I had to, and I think we mentioned it in one of the previous talks, you have to be your best self-advocate. And so when I was at the hospital and I wasn't getting the answers that I needed, I took that away from them. I found my own person that I was going to deal with for sexual rehabilitation afterwards. Oh, sorry. And so I found my own sexual rehabilitation doctor, who happened to be my urologist before I had all my surgeries. So it is important, I would say, to be your own best advocate. If you're not getting the answers you need, then I think you need to ask other people. Yeah. And I would have had that conversation brought in the very beginning. And I would tell that to any doctor or any patient that's going through this, is those are information, those are questions that we need to know answers right up front.
Right up front. Lisa, what do you think?
Well, yes, because I have a very wonderful, famous doctor who made me very healthy, but he didn't speak at all about what would happen to me gynecologically. I mean, they said, oh, yeah, we'll take out this organ and that organ, but they didn't speak about the vagina. They didn't speak about it being cut up into pieces and then any of the rehabilitation. And when it was very painful and I came back to the doctor and the fellow said, oh, we don't look at that. I said, you have to. It's burning me. It's killing me. I can't even sit down. And they said, no, we don't look at it. And I just had to scream. It was so embarrassing to scream at a young doctor to please look at me. And they did. And then he went and got the surgeon. But I think that you have to advocate for yourself, but also it can be very embarrassing and it can be shocking in a sense because you didn't know it. And then he said, well, I told you this and this, but somehow when you're getting treatment or you're discussing treatment, you don't always hear all those little pieces that come being thrown at you. And then I think it's hard for women when we have a male doctor who doesn't really focus on women's health that much.
But, you were your own advocate, right? You did your own research and you knew
Yes.
that your sexual function was going to be affected. Now, did your surgeon ask you if you were sexually active before the surgery? Was that addressed? No.
Not that I remember.
Right.
So in all fairness, but it wasn't enough. If they did and mention it go briefly, I don't think that it was ever discussed.
Okay. So, and Brian, did your surgeon ask you if you were?
Yeah, that was discussed. And I think one of the things we're talking about now is sex versus sexuality.
Mhm.
Are you sexually active? Yes or no? But the thing that really was problematic in the healing process wasn't sex. It was the damage to my feeling of identity and masculinity, of waking up having, the word I use is gutted, right? I felt like I was gutted and that I was no longer the person that I had been. And it took me a long time to recover from that. That was never discussed or mentioned in a medical setting.
And I would just say, from my perspective, hearing your stories and we'll get to questions in a moment, I would say we as providers, we are very scared to overwhelm the patient. We know that there's a lot of information coming at you and there is this certain mental bandwidth that we've talked about, that how much information can you take and at what time and in how many sessions and when. And we don't want to scare the patient. It's already a lot to go through. There's so many appointments. And so I struggle with that as well, because I want, the moment I see patients, I want to tell them, we're going to mess up your sexual function or sexuality. We are not going to make that better. And sometimes I worry that I take away their hope or their joy or their identity or their choices. Can someone speak to that? Like, would you want that for me to say that right away? Brian, it seems like you would have wanted it. Elisa?
Hi. Thank you. I think instead of bringing it up in the concept of this is what's going to happen to your either your sexuality or your performance ability or your enjoyment, it needs to be said if or when you're ready to ask me questions, how this is going to affect your performance, your sexuality, your ability, then I'm here. And that way, that gives them their choice to say, oh, now I'm ready. It could be right that minute, because that's what's important to them. It could be later when they're recovering. I just want to share something. My husband does that survivor to survivor. And he actually has people that's their first question to him. Yeah. I mean,
In one case,
yeah,
in one case, that was the first question.
Yeah.
And, I'm non-muscle invasive bladder cancer, and, I'm okay. I'm in a pretty good place. So I would tell them my experience with it. But I think that always has to be, I think, you mentioned a concern about overwhelming a patient. As a patient, I would want to hear the complete story. I wouldn't want anything held back. So I would, as my wife said, mention what it would do to your sexuality, and give the patient the option whether they want to hear it now or later. As from my personal viewpoint, I'd want to hear it right away.
Mhm. Few hands going up.
So I got diagnosed and had my surgery, which was a full bladder removal during COVID. So another complication for me in terms of information that I was receiving was it was all by myself. My wife was not able to be there in person because of the protocols at the hospital. Now we were able to do a FaceTime type situation, but it's not the same, and it's not as spontaneous in terms of the response and the questions. And frankly, the discussions I had with the surgeon were overwhelming because we talked a lot about the surgery itself, how long it would be, how involved it would be. And we talked about an ileal conduit, which I had never heard of before. I had no idea what that was. When I think of conduit, I think of an aqueduct stream, which is actually a good analogy. And then a stoma. What the hell is a stoma? I mean, this thing sticking out of my belly. So, and then he also mentioned that he said, by the way, in all likelihood, I will probably have to remove your prostate because it normally goes with a radical cystectomy. It's all part of the whole package. And I said, okay. I did ask after I, trying to absorb all this, I said, well, what about sex afterwards? And the response he gave me in retrospect was quite comical. He said, well, that's going to get a little tricky. So I'm still waiting for the magic wand abracadabra moment of when this trick comes about. So to make a long story short, I agree. There should be a session prior to surgery dedicated just to sex and sexuality, because that is important. Immediately following the surgery and for weeks and months thereafter, sex was the last thing on our mind, frankly. It was the healing, the surgical healing, and dealing with the stoma, dealing with a pouch and everything else. But it's now been a year and a half, and so it's obviously still something up there. So I think it should be something that should be dealt with as almost a separate discussion with partners and the surgeon to say, okay, this session is not going to be dedicated to surgery, but to sexuality.
And that is, we actually, in our discussions, we thought about, well, should it be part of the woundostomy appointment, right? Everybody has that appointment, but during that appointment, you're going through so many other details, new vocabulary, new appliances, where are you going to get your supplies? How are you going to do this? Can you do this yourself? So at that time, that also seems not appropriate because that should be its own session. Any thoughts on that? Lots of thoughts.
Thoughts on sexuality here, yeah.
Yeah,
Yeah.
I was going to say, the gentleman before me, you captured it perfectly when you're talking about, I have this wafer and I have this bag and somehow I have to stick it on my stoma perfectly round when it's not. It's overwhelming, but I would prefer to have literature and a resource after after I'm healed, now I can deal with the sexuality issues. Now I'd like a research. So I think everybody's a little different, but the only information I've gotten is from BCAN on any of this, and some of the survivor to survivor, and some of the information on the websites. And my physician, who is outstanding at the surgery, did not address that at all. And I do think in the physician world, there is a place. It might be different for each patient, but please let us know what's coming.
Oh, Elisa, while we're getting to them.
Over here and then we'll come back.
Okay.
So being part of the women's side where we're a minority, I've been part of a women in sexuality study. And in the study, all the attendees should have been sexually active and were not, because after the surgery, they felt that that part of their life was over. So unfortunately for what I feel like women, I think when I was going into surgery, I felt like, well, my life's over on that. And it's really different for women because they just ripped out uterus, they ripped out everything. So I was very fortunate. I had a surgeon that was studying and doing work on organ preservation. So I kept everything other than the bladder. And of course, there was some vaginal wall issues. But after the fact, and I think that would have been good if my surgeon or my oncologist said, hey, why don't you go see the pelvic floor specialist? So I think the person that gave me the most hope that, hey, I think I'm going to flirt a lot now is the pelvic floor physical therapist, where a lot of attention isn't brought up to that person. I went to an advocate meeting and a physical therapist that specialized in it said, hey, this is what I do. And I said, let me make an appointment. So I made an appointment immediately, and I was walking to the appointment. My surgeon saw me and said, what are you doing here? I said, oh, I'm going to physical therapy. He said, really? I said, yeah, it's my first appointment. He said, have fun. And having that person that's kind of part of the team, because as everyone says, when you're getting the surgery, you're just going, wait, what? No. And you're trying to deal with all the mechanics of everything. And you're exhausted after the surgery just to think about, yeah, he's cute. But unfortunately, it feels like in the years since the surgery and meeting the women that I met, a couple people have made attempts and they're just like, yeah, I'm alive, I'm good. But it needs to be more than that for women, I think.
Yeah, and I think when I also had it, I went to the support group for gynecological cancers at the hospital, and it was all women, and they actually brought in the sexual health doctor to the support group. They brought in the fitness specialist who talked about the pelvic floor and other things, and they actually had each one of us go to the sexual health physician to use all kinds of dilators and creams and things that no one mentioned in the bladder world. So I think that, we have to actually, we shouldn't have to search for it, but we do. And we need to see, well, what I would never have known about those things if it weren't for the gynecological group. Yeah.
Right. And I think this is one of the difficult parts of treating women with bladder cancer as a minority in this diagnosis. Urologists are not attuned to the needs of women. And so we do have to reach out to our colleagues in other pelvic cancers, like colorectal surgeons and like gynecologic oncology surgeons, and glean the resources from them, because with men, we're fortunate, well, not fortunate, but we have the experience of the prostatectomy literature and how that affects their sexuality. So we can easily, recite out all of the different treatment options, from medications to injections to surgical interventions. But for women, there seems to be this focus of more on, the psychotherapy aspect of it, or maybe you should talk to somebody. Or oftentimes, if someone sees that a woman is not partnered or married or widowed, it's not important anymore. Or the woman herself may say, oh, that part of my life is over, because maybe that's what they're expecting for the provider to say. Like they think that that's what the provider wants to hear, because maybe, they shouldn't be sexually engaged or sexual at their age, although it's not true. I mean, we've done the studies. Older adults are sexually active. They are thinking about their sexuality. And so we really have to overcome that uncomfortable feeling of not talking about it.
And I think we have to overcome that uncomfortableness within ourselves. And I was thinking, particularly during the mindness meditation, that one of the things that I did for myself in my own sexual rehabilitation was to try and figure out how I felt now. So even though I didn't have erections, I would still masturbate to see what it felt like. It was different. I had to learn how to feel things. I had to learn how to achieve an orgasm again. Everything was different, but I took it upon myself to educate myself on how I could recover. Not knowing, I wasn't dating anyone, and I got divorced just in time to get cancer. So, but so I was doing it all by myself, but which kind of gave me a lot of free time. So that was good. But I think it's important to take that time for yourself to feel how you feel, because it is different. It is all different, and shouldn't be something that scares you, that difference.
Right.
I think it's just experience the difference, become comfortable with the difference, the new normal, as we talk about it. And I talk about it as my new body. It's basically the same body, but I experience it differently.
Yeah, I think that's a really good point. We have a comment. Yes.
I just wanted to speak to my own experience. So I was diagnosed at 39, which is, an anomaly for cancer patients. So one of my first questions did have to do with sexuality and sexual function. And I was fortunate that my surgeon and my oncologist were very forthcoming, and they responded to those questions. But I felt like it was still very, they would tell me how things were going to be affected, but there was no referral to, say, sexual therapist, or there was no discussion about identity and body image, and something. There's such a focus on genitals and sexual function, and something that changes in both men and women is now you're scarred and you look different, and maybe you don't feel sexual or you don't feel sexy, right? And I guess my question is, how common is it to send a referral to a sexual therapist to focus not so much on the mechanics of sex, but on intimacy and reimagining what sex can be if you don't have the potential for an erection or have other barriers that you can't overcome?
Yeah, that's and that is a really good point. And so there's actually, and I'll send a few of the websites after this session, but there's actually two really good websites where you can find online a sexual therapist. They're accredited sexual therapists that you can speak with, because, the medical community right now, I mean, we are so short-staffed. Not all institutions will have a sex therapist and a rehab program. And so oftentimes the reason why these things are not brought up is because the resources are just not there. And so these two websites, NSTAR and ASECT, and Stephanie, I'll give you the links. You can, in the privacy of your own home, find a sexual therapist to reach out and speak with. And now with telemedicine being so available, just like it's been helpful in mental health. In this respect, also, it's really opening up the venue to discuss these topics beforehand, during treatment, after treatment. That's sort of what we're trying to figure out here. When do we address these things?
Have you scheduled to speak with a sex therapist in the next couple of weeks? I can't remember the date off the top of my head, but you are going to be doing a webinar for us. So we'll deal with the physical and psychosocial aspects of that is sex therapist, and how do you find one? So I think she'll be really helpful in bringing that forward. So we'll have that great resource on our website also.
Thank you, Stephanie. Yeah.
You talked about, having the discussion. The challenge is, and this was brought up at think tank, is you have X amount of time, maybe 15 minutes to deal with, oh shit, I have cancer. And then it becomes blah, 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 blah. And then the next meeting was, okay, the surgery is scheduled. This is what your bag is. And then there's not that time. And there's no standard of care, shall we say, of my hospital did not do a woundostomy meeting. The pre-op session with a resident was worthless, in my humble opinion. And, there's no standard of care across, AUA or any of the standards organizations that, we can say, yes, here are resources that we patients can refer to. And that's kind of why, I even proposed to my doctor that, hey, Beacon has this new grant program. What if we did even standardizing the care in clinic in preparation for cystectomy? And he said, well, we don't have the wide enough network for that to propose it. But, there needs to be greater standards of care and of access to information, because, even vaginal sparing for women, it, comes up occasionally. As you said, for us men, it's very common that, doctor said, oh yeah, we'll do nerve sparing if possible. And there was that asterisk that even, oh geez. And I remember the guy online on Inspire saying, I have to have this kind of surgery with prostate capsule and blah, blah, blah. It's like, dude, if he's in there and it can't happen, you can't insist because you'll be under. But, it's how do we convey to other people that, these are the options, but again, you only have 15 minutes. What do you do?
I think that was one of the things we were talking about, is who provides that information, and is it the surgeon? Because I don't believe that it should be the surgeon. I think the surgeon is there to cure my cancer. That's what I want them thinking about and focusing on. And I think there needs to be a third party aspect of it, but it needs to really be elevated in importance. And I'm not sure it's the ostomy nurse either, but love my ostomy nurse, would have had those conversations with her, but it seems to be a complete void, just completely ignored.
Yeah, but Brian, the surgeon is doing the cutting. So there is an aspect that the surgeon should know what your concerns are. And because you were even saying to me yourself, I will do a different kind of surgery depending on what the needs of the patient.
Yes. And this is where, and I think this idea of, as a surgeon, it's not my job, it's not my place, somebody else will address it. Well, we have NCCN guidelines on cancer survivorship and sexuality and how to help people achieve their sexual goals. But who is doing that? Is that the medical oncologist that's seeing the patient every 6 months or 3 months? Is it the primary care doctor? Is it the psychiatrist? But this idea of, well, I'm the surgeon and I shouldn't be wasting time discussing this. We should be initiating the conversation and saying, these are the things that we will affect. And then enlisting the support of multidisciplinary folks on how we help you. And right now, I think the trouble is we don't have the team. We don't have the team across the country. I mean,
I do think you have the team, but it's underutilized, and that's the patients who have gone through surgery. In my own experience, I think that pre-operative attendance to support groups that are not managed but facilitated by some professional like social worker trained in aspects of urology is a resource that is extremely underutilized. I'm a 10-year MSK patient, and it's only by rumor that patients get even to our previously live and now virtual support groups. But personally, myself, most of the information I received was from the support groups, and pre-op visits to reasonably attended and reasonably supervised support group is a resource that's extremely valuable and extremely underutilized. It's a place where people who were maybe shy about talking about lifestyle topics, whichever they may be. I know we're talking about sexuality, but there's a range of things that they can be brought up and experiences shared and people gotten on the right track and directed in their regional support group to the professionals they may need, whether it's pelvic floor physical therapists or someone who can do a penile implant for impotence that's not responded to non-surgical treatment or a range of spectra.
So would you say that should be, for those that have received neoadjuvant chemo, there's a mandatory chemotherapy nutrition class or video you have to watch for some people, I think. But okay, well, certain places have it. But so should that be a mandatory or not mandatory or?
Mandatory, but I think you should, I think it's, I respect the surgeon's time strategy and how people blank out when they're in the cancer discussion. But it ought to be the responsibility of the team who are intaking the patient and being indicated for radical surgery to direct them pre-operatively to the support group to allow them exposure to people who have walked in the path that they're about to.
I belong to that same group, and it was Neil who helped me so much before my surgery, and it was really great. But being the only female in the group, I didn't get much support about what to do about my other things. In fact, one day he didn't come in, remember? And I started talking, well, you know what happens to the vagina? And all the men went, really? Because we never discussed it because I was the only one. But the thing is that the support group with the GYN, that person was absolutely fantastic. And she talked a lot about sex. And she gave us books. And she gave one book called Sexual Intelligence by Marty Klein. And it lets you think about sex in a very different way. I mean, one thing that he spoke about in the meditation, he said at the end, I'm a Catholic and yoga was pagan to us when we were young. And I think that for many people, we get different narratives about sex when we're young. Some people are told not to masturbate. Some people are told not to do this or only for procreation or whatever. And so we have a narrative. And so these books they talk about the history of our attitudes towards sex. And it talks about not telling us what to do, but just to open our mind to whatever we want. This book is called Transforming Sexual Narratives. It's a little more clinical, but I never read anything like it. So I think that we should also be helped to be educated about these things that, I don't know, it's a good opportunity to rethink things that we didn't think about before.
To reiterate a thank you to BCAN because they provide a state-by-state resource for support groups. And I think I would say at this point, now sort of a year and a half out, my greatest support on recovering my sexuality and my feeling whole again came from these conversations in support groups. So because we all know what it is to go through that, and I think the doctors don't. And so that support group, my sexual health doctor recommended me to one, and that's how I sort of got into my first one. And then and they are extremely helpful both pre and post.
Yes. And these conversations have been mostly about the surgical aspects on the sexual organs and how those change. Now, I only had neoadjuvant chemotherapy and I had my kidney removed. I think chemo has messed me up in tons of ways because I still feel things are different than they were prior. In like, I don't know, I get sick quicker, my skin's bad, I've had more issues. It's like, why, in this past year. So even though I have my sex organs, I didn't have that type of surgery, but I just feel like it's been affected as well. And so I think we need to also make sure that it's not just the surgeon who's going in and doing these radical surgeries, but it needs to be part of the cancer talk somewhere to all the patients, because it affects, and I don't know if this is forever or if things will change and get better. Or do I need to take another vitamin? I'm taking like handfuls, but yeah, so I think it just needs to be part of the discussion.
Yeah, I think that's the place of the sexual health doctor who doesn't only see bladder cancer patients, but any patient who's been adversely affected by his or her treatment. Yeah, I agree.
Comment in the back.
You started this by, when should you open the conversation with the patient? Well, my doctor I went in with a list of questions and with my wife, and one of the questions was all about nerve sparing, sexual function. And she said, well, are you two sexually active? Yes, we're old people, but we still like it. She said, well, I'll break you of that nasty habit. But, so no, she didn't say that. That's a joke between her and I. But she said, my first protocol is bladder sparing, and we're going to work on that. If it comes to the point where I already knew about radical cystectomy and prostatectomy, and she said, at that point, we'll discuss it. We have good people in the practice who before and after can talk to you about that. And just like you said, she's the surgeon. She goes, I'm going to damage you. Sorry, but we're going to do everything we can to make it better. And I was very lucky. They have a nurse practitioner who I call her my erection specialist. And she was amazing. And she knew all the protocols and everything and what to do. And it can actually get better. And it did. So, but the conversation from the doctor was right up front. It was, very candid. But she said, when we get to that point, we're going to have, more discussions.
So we have about 10 minutes. So I kind of want to summarize some of the things and themes that have been brought up so that we're all sort of on the same page, and maybe bring up a few more if there's still lingering thoughts. But so we talked about so first of all, do people want to hear this information before surgery? Who should be having this conversation? What are the available resources and access to them if certain institutions don't have them on site? having partners or caregivers be in the discussion. So it sounds like we should probably say, this is what's going to happen. Do you want to hear about it now or later? Is one comment in the middle when you guys made that comment initially, because everyone is different. So we should provide as much information as possible. I think the worst thing that a patient wants is feeling like something's being hidden or not disclosed. And so having that conversation in the beginning saying, here are all the facts. Which one do you want to address and when? And then if I'm not able to address them, maybe I refer you to, or definitely refer you to support groups in the beginning, before the surgery, before the chemotherapy. Any other thoughts? Yeah.
I think one thing you mentioned earlier was about the self-identity and your feeling as a person, a whole person, and including sexually. And I think that those sometimes are hard to, I mean, sometimes we might feel depressed, but we might not identify it as being that you can't have sex or you don't feel. And I think it can be very confusing to know what's going on. And that's why I think it's important to speak to someone, not just about the sexuality, but about how we feel in general. I'm not feeling good, but maybe it is connected, but maybe it isn't. But I don't know. I think we have to have that idea of feeling whole again in many ways.
Brian?
I think almost a wellness conversation, right? Rather than breaking it into all of these separate smaller things. You're going to lose your erections. You're going to, it's going to be this, but rather if a holistic approach to this is who you are when you wake up, right? You're going to be a different person, or after your first TERP, or how you're going to feel during BCG. I mean, everyone, wherever their step is, has complications, I think, wherever you are, because you've received that diagnosis. From that moment on, it's different. And how you deal with that difference is generally left to us. And I think, finding our own resources is helpful. The finding BCAN was extremely helpful. Finding support groups is helpful, but it is important to, I think, to understand that change happens, and that it is traumatic, and that you are from that moment on dealing with that trauma. And I think it takes a while for that trauma for you to be able to incorporate it, to identify yourself differently. And that changes over time too. I'm a year and a half out. I'm still changing, and I expect to be checking in on myself, for a really long time to see what changes are happening. So, and I think that's important too, is just to constantly be mindful, go back to that, and be aware of who you are today and tomorrow and the next day.
Yeah, I think that the mindfulness preparation and also the discussion on trauma was really great. And we can sort of link all these things together of how we feel.
Yes.
Hi, I'm Karen. I'm a nurse navigator as well as a patient survivor. One of the things that I struggle with my patients is that I would love to refer them to resources, but the insurance coverage is lacking, or they don't have insurance. Are there resources out there for sexual therapists that are like free resources, or what would you recommend?
Unfortunately, I don't know about free resources. Do you, Elisa? Oh, okay.
I mean, there isn't enough free stuff. but the support groups are free. Brian started his own support group. And so, yeah. And I think that, you have.
New York City.
Yeah.
New York City.
And you have, and I think there's that, perhaps we could all think about what books, what sort resources that we have and pool them together so that people come together and read the same book, talk about it. It is hard, I think, when the insurance don't pay it. And frankly, not all therapists are great. I mean, there are really, really great ones, but there are ones who, maybe you would rather not see them. You know what I mean? So that's why it's good that we help each other and find sources together.
My concern, I have to say, is those people, patients that aren't looking. They're dealing on their own. They weren't given a BCAN handout. Carlos, my husband, had bladder cancer, over 5 years ago. He went to a great university, Ohio State University, for his care. He was introduced to BCAN there. Thank God, because I got cancer, upper tract. In Charlotte, where I went for my first urology appointment, where they did the scans and stuff, they didn't hand me any BCAN info. They're not telling me about any other stuff that's going on. They weren't even going to do chemotherapy. Thank you, Carlos, for being involved. So then I could get better care and I could get all this information. But there's tons of people out there that aren't us in the room, that don't have people like Carlos who's involved, or me, who sometimes I hole up sometimes and aren't looking. So we need more. We need it done in all urologies, offices need to have something there that's a handout everywhere across the country, Charlotte, not just Johns Hopkins, so anyway.
No, I think that's a great way to probably end the discussion, that this needs to be a holistic approach to the whole person. It can't just be in a piecemeal fashion. And I think I applaud BCAN for having these summits. I learned so much. I learned more from you guys than, you probably learned from me, honestly, but and it inspires me to continue to keep going and to try to be a better physician and to advocate for patients and to talk to the other surgeons and kind of continue these conversations. So thank you.
I thank you.
Yes,
This
yes.
has been wonderful. I know we could keep a dialogue going for a really long time. Really quick, Jim, really quick. So thank you so much for this fabulous discussion.